starting now. Good morning, everybody, and thanks for being here in Clinical Approaches in Cardiology. Today, I have the honor to present you Dr. Uri Elkayam. He is a professor of cardiovascular medicine and obstetrics and gynecology, University of Southern California. He is also the director of maternal cardiology. He is a fellow of American College of Cardiology, fellow of American Heart Association, and American College of Physicians. He is also a JACC editorial member, among others. Professor, we feel really honored to have you here with us today, and please go ahead.
All right, thank you. Thank you for having me. So we're going to discuss valvular heart disease and pregnancy. I'm referring you to the ROPAC registry. This is a registry that took place between 2010 and 2018 in 53 participating centers, mostly in Europe, the Middle East, and Africa. The registry was able to recruit almost 6,000 pregnancies. I am mentioning the registry just to give you an idea as to the profile of patients that the world actually see with heart disease in pregnancy. So while in the past it was mostly valvular disease, then at present we have more patients with congenital heart disease. And that's because of the fact that patients with congenital heart disease survive today to adulthood and childbearing age. And so you can see here that 56% of the patient had congenital heart disease, but still there is a sizable population with valvular disease. And when you're looking at the profile of patients with valvular disease, then in red, it is mostly mitral valve disease, either mitral stenosis, mitral regurgitation, or the combination of the two. And I'm going, since I have about 30 minutes or so, I'm going to focus my presentation on mitral valve. So the causes of cardiovascular complications in pregnancy have to do with the hemodynamic changes, mostly, but also pregnancy as arrhythmogenic. So it is anticipated that you're going to see more arrhythmias. And also the changes in hemodynamics will provoke arrhythmias like atrial fibrillation and supraventricular tachycardia, but also sometimes ventricular fibrillation. Thrombogenic effect. So there is anticipated that the incidence of thromboembolic complications will be higher than usual. And then the side effects of the drugs and the interventions that we may want to offer the patient. You can see here that the different groups of patients within the ROPAC registry, and you see that the number one complication was heart failure. This is congenital heart disease, valvular heart disease, cardiomyopathy, a small number of patients with ischemic heart disease, and pulmonary hypertension. So between 7 and 33% of the patients develop a heart failure. And the reason for that, obviously, are the hemodynamic changes. So on the lower part of the slide, you see the change in volume. So the change in volume starts relatively early. And then in the sort of the end of the second trimester, you have a substantial increase in volumes, about 30%. And the upper part of the slide shows the effect of this increase in volume on the stroke volume. This is the middle line here in red. So there's about 30% increase in stroke volume. And obviously, there's also some increase in heart rate, and the combination will be an increase in cardiac output. So when you have a patient with limited cardiac reserve, these patients are going to either present with heart failure for the first time during pregnancy, or they're going to have increasing symptoms and deterioration of hemodynamics. The timing of the presentation you see here on the right, as anticipated because of the hemodynamic changes, is about the end of the second trimester, the beginning of the third trimester. But then you see there is another bump after the delivery, and I'm going to come back to this during the delivery and after the delivery. So as a rule, the ideal situation will be to see the patient before they become pregnant. In reality, it is not really happening because patients usually present to see a physician when they're pregnant, when they have some symptoms. But again, if all possible, if you have a patient that you have been following for a while, the patient have to be notified. If they have heart disease, they want to become pregnant, they need to have an evaluation before the pregnancy. If it doesn't happen, then you want to evaluate them as soon as possible after becoming pregnancy. So a careful cardiac evaluation. Now, the history is extremely important. If the patient has a history of cardiac symptoms or complications, it is very likely that this will happen again during pregnancy. We want to know something about the physical examination. The EKG and the echo is extremely important. It's really the gold standard test that we're using in order to determine the anatomy as well as the function, as well as the hemodynamics. The MRI of the aorta in patients with bicuspid aortic valve, if you don't feel that you have good view of the ascending aorta by echo, the assessment of functional capacity, very important. So we're doing an exercise test. Now, a lot of these patients are not really used to exercise. They lower their activity to match their potential in terms of the cardiac disease. So oftentimes the patient will not perform well on the treadmill because of decondition, because of the fact that they are not really used to exercise. So it's important to do a cardiopulmonary exercise test. It gives you an idea whether the patient achieves the metabolic threshold, we call that, as an indication that they really has made an attempt and they basically exhausted their capacity. So we really spend time on that. Unless you have a patient who is very, very active, the patient is jogging, the patient is hiking, then it's really important to have an objective assessment of the exercise tolerance. We really have a value BNP or NT-proBNP. So we will assess the level of BNP at the first time we see the patient as a baseline, and then we'll follow the BNP along the way, really as a surrogate of intracardiac pressure. And then we don't hesitate to do invasive hemodynamic evaluation in patients with relatively severe heart disease, and do a hemodynamic evaluation either at the bedside or in the cath lab to really establish the hemodynamics at the beginning, to establish the relationship between the symptoms and the hemodynamics, and to establish the relation between the BNP and the hemodynamics. A sort of a useful rule is that stenosis is less tolerated compared to regurgitation. The location, for example, mitral stenosis is less well tolerated compared to aortic stenosis, and pulmonic stenosis, pulmonic valvular stenosis, is tolerated very well. So the degree of stenosis, severity of valvular stenosis, but also the location really matter. Mitral stenosis is not tolerated well, and I'll show you that. Aortic stenosis, depending on the severity, but it's tolerated better. Mitral regurgitation and aortic regurgitations in principle are tolerated well, depending on the ventricular function, depending on the pulmonary hypertension. But if the patient does not have a complicated mitral regurgitation and aortic regurgitation, even if it's severe, They usually tolerate it well. The ventricular function is important. Pulmonary hypertension is very important. History of cardiac complication prior to pregnancy, as we mentioned, is an indicator for complication during the pregnancy. Everybody loves to use the WHO classification, and it's useful as sort of having an understanding of who is going to get into trouble. So the patients who are, according to the WHO classification, risk class 4, these are the patients that may have mortality and certainly will have complication during pregnancy. This will include, again, the pulmonary arterial hypertension of any cause, severe systemic ventricular dysfunction with ejection fraction less than 30%. Obviously, the patient who present with class 3 or 4, New York Heart Association class, when you see them first, these patients are going to get into trouble. Previous peripartum cardiomyopathy with any residual impairment of left ventricular function. This patient, even if they normalize, they may actually present with relapse of the same condition that they had before, and some patients can develop severe heart failure. Severe symptomatic mitral or aortic stenosis, severe symptomatic mitral or aortic stenosis. So it really has to be severe and it has to be symptomatic. The Marfan syndrome with aorta dilated to more than 45 millimeter, aortic dilatation more than 50 millimeter. This is in patients with a bicuspid valve. Notice that there is a difference between the threshold here, 45 and 50. And the reason for that the patient with bicuspid valve, they have aortopathy, but the likelihood of dissection during pregnancy is much less than the Marfan. And then the native severe coarctation. So these are considered to be very high risk. There's some exaggeration because some of this is manageable, especially if you have a patient with mitral stenosis, aortic stenosis. You can treat the patient with medication or intervention, but in general, these are the high-risk patients. The second predictor system is the CARBREC2 that from the Canadian group, a large number of patients, mostly congenital heart disease. This group in Canada really specializing in congenital heart disease. And they tell you again that the prior cardiac event or arrhythmias is very important. So you have to spend time and take a good history with your patient. The baseline New York Heart Association class presence of cyanosis is mostly going to affect the baby. Mostly going to affect the baby. Mechanical valve has its set of problems. Systemic ventricular dysfunction, as we said. High-risk valve disease, as we mentioned. Pulmonary hypertension, high-risk aortopathy, coronary artery disease, and late pregnancy assessment, no prior cardiac intervention. Obviously, if you have a patient with mitral stenosis severe, you can do an intervention and change the outcome of this patient. This is a one-center study from India of patients with valvular rheumatic heart disease. And you can see here the distribution of conditions within this group. They had patients with mitral stenosis, they had patients with mitral regurgitation, they had patients with aortic valve disease. But if you're looking at the predictors of adverse cardiac outcome, then again, consistently you see that the prior cardiac event is very important. Severity of mitral valve disease is very important. And pulmonary hypertension. They say valve replacement because when you have a prosthetic valve, especially if it's mechanical, then obviously the approach to this has to be different, and you need to be able to provide excellent anticoagulation. Otherwise, you're going to see complications. A general rule, another rule regarding intervention prior to pregnancy, So if you see the patient before pregnancy, those who meet the criteria for intervention based on symptoms, pulmonary hypertension, atrial fibrillation, decrease in exercise tolerance. So remember, valvular disease, the first indication is symptoms. The second indication, left ventricular function. Third indication, hemodynamic compromise and pulmonary hypertension. In patients with mitral valve disease, atrial fibrillation, decreased exercise tolerance. In all conditions, this patient should undergo such intervention prior to becoming pregnant. So if you can do that, unless you have a patient that requires a prosthetic mechanical valve, then you're going to create a situation that pregnancy will be tolerated much better. So do the valvuloplasty before the pregnancy. If the patient needs to have a valve replacement, unless you're going to put in a mechanical valve, which is going to create some problems, then the intervention should be done prior to the delivery, to the pregnancy. Another general rule, which is equally important, is that you should not do prophylactic intervention or surgery. If the patient does not meet criteria for the intervention, surgery, then the pregnancy will be tolerated well. An example, a patient with severe mitral regurgitation who still has normal size of the left ventricle and the ejection fraction does not meet criteria for intervention, and the patient does not have pulmonary hypertension and exercise tolerance is still normal. This is a patient that you would not do surgery without pregnancy. The pregnancy will be tolerated in a patient like this well, and there's no need to do surgery because of the anticipation that things will be getting worse during the pregnancy. You don't really want to have premature intervention. Obviously, if you want to do a valvuloplasty in a patient with severe mitral stenosis or moderate, that's one thing. But if you are going to replace the valve, then if you're replacing a prosthetic valve prematurely, remember that these valves will deteriorate and deteriorate relatively fast. And a patient with mechanical prosthesis, as I said before, it's making pregnancy more complicated. Not that it is not manageable, but you really have to have a system that will make sure that the patient is getting excellent anticoagulation. And this is not available in many centers. So mitral valve disease in pregnancy, you can see here that in spite of the fact that in the EUROPAC registry, it was a majority of congenital heart disease, acquired valvular disease still remains worldwide a common challenge for pregnant women and their clinician. I would think, I don't know for sure, that your new country, you still see patients with rheumatic valvular disease. This is one center in India, acquired heart disease, like a registry, a local registry of almost 700 patients. You see the majority of the patient, rheumatic heart disease. In China, among over 1,000 pregnancies, then it was equally divided between patients with congenital heart disease and patients with rheumatic valvular disease. So in certain areas around the world, valvular disease is still very, very common. Some of the questions I would like to discuss, the pre-pregnancy evaluation I've discussed already, the anticipated outcome in women with mitral stenosis, if we talk about mitral stenosis during pregnancy, what is the effect of mitral regurgitation? What can be done to reduce the risk to both mother and fetus? And then I'll talk a little bit about the delivery, when and how, and the early postpartum care. So this is now coming from a recent paper that we published in the new journal, JACC Advances. This is what I call the cardio-obstetric valve team, in order to be able to provide excellent care to patients with complicated valvular disease. In the United States, and I'm not sure now what's the situation in Colombia, but we have developed the concept of cardio-obstetrics. So this is a partnership between the cardio-obstetric cardiologists. So this is a cardiologist who is interested in taking care of pregnant women, the maternal fetal medicine. This is obviously a subspecialty in obstetrics and gynecology. The cardiologists need to be somebody that really has experience with valvular heart disease. And you have to have an advanced echocardiography because we rely on the echocardiogram. And if you don't have a really expertise in echocardiography, then we see oftentimes a lot of mistakes. The cardiac radiology. So if you're doing procedure during pregnancy, you want to have somebody who's going to help you to estimate how much radiation the baby is going to be exposed to. Then, you know, if you're into doing TAVR, doing balloon valvuloplasty, then there's a structural cardiology. You may need to consult the cardiac surgery in a patient with deteriorating. And then you need anesthesiology, either obstetric, cardiac anesthesiology, depending on the situation, and a combination of the two. Neonatology in a patient that present early because of deterioration of disease. You want to be able to assess the viability of the baby and have some kind of a planning in terms of trying to prolong the pregnancy, the pharmacy, the nursing, social work. So it's an entire team of physicians and healthcare personnel that really need to help you to take care of this patient. The one word about the echo, as I said before, you can see here, this is a report of an echocardiogram in patients with rheumatic mitral valve disease. And the statement is it's moderate to severe. You can see that with the echocardiogram, oftentimes, you cannot make a commitment to either moderate to severe and then mild mitral regurgitation. The mean gradient is 19 millimeter. That's severe. And then you see that the calculation of the valve area is 1.5. This is moderate. So is the patient having severe or moderate mitral stenosis? And whether you're going to use this kind of information in order to make major decisions. Valvuloplasty during the pregnancy, early delivery, C-section delivery. So you have to understand the limitation of the echo. And if you're not sure, if the symptoms and the echocardiographic results don't really match, you have to ask for help. And the help, I mean, the BNP in patients with mitral stenosis, the BNP is not going to be as high as in the patients with heart failure. But there is correlation between the PA pressure here on the x-axis and the NT-proBNP on the y-axis. You can see it here. So it does give you, especially if you establish the baseline and you follow the BNP along the way, and you see the BNP is going up, then you know that there is really hemodynamic deterioration. So let me present you a case here with mitral stenosis, 29 years old, 5th pregnancy. The patient is now at 24 weeks gestation. She has a history of valvuloplasty several years back. She was asymptomatic prior to the pregnancy. Now, when we say asymptomatic, I noticed that I did not actually present you the exercise results because she was not exercised. She came to see us during the pregnancy. According to her, she was asymptomatic. But remember, the patient with valve disease. This is developing gradually, and they will lower the activity gradually. And they say they are asymptomatic because they don't do much. The New York Heart Association functional class 3 now at 24 weeks. Remember, we said that this is the time that the hemodynamics will be maximized in terms of the stroke volume. You have a high stroke volume, it has to get through a stenotic mitral valve, and obviously the pressures will go up and the patient will develop deterioration of functional capacity. The mitral valve area is 0.9. The peak and mean gradient, so the mean gradient is 11. The left atrial size is enlarged. There's no mitral regurgitation. The patient is still in sinus rhythm, and the heart is relatively fast, which is an opportunity. You have a blood pressure which is borderline, so you may be concerned about giving a patient a beta blocker, and the message for me is you should not be concerned, because this is the target, the 90 beats per minute. You're going to slow down the heart rate. The blood pressure, if anything, is going to go up. So what happens in patients with mitral stenosis? For two reasons, the left atrial pressure will increase. The first one is the volume, and the second one is the fact that the patient will develop an increase in heart rate. And here in the middle, you see what happens when the heart rate is going up. You see it here in the bottom. This is the vertical axis. So the heart rate is going from 34 to 146. The diastolic filling period, the time which is allowed for the blood to go from the left atrium to the left ventricle, is decreased. And because of that, there is a decrease in the mitral valve flow. There is a decrease in the stroke volume, and there's an increase in the wedge pressure or the left atrial pressure. So there is a significant increase in the left atrial pressure proportional to the increase in heart rate. So that's by definition going to happen unless you're going to prevent the increase in heart rate. Now here you see a group of patients that we studied really over 20 years ago in our institution. And you can see that 74% of the patients had deterioration of the New York Heart Association classification. All the patients at the first time they saw us were in the New York Heart Association functional class 1 or 2, and then 70% of them deteriorated during the pregnancy. So that's almost by definition. So what is the outcome of this patient? This is taken from the ROPAC registry now. They had about 200 patients with mitral stenosis. So you see here that there is a high incidence of heart failure, and the more severe the stenosis, the higher is the incidence of heart failure. Some of the patients required an intervention. Some of the patients had arrhythmias, about between 6 and 7% of the patient, depending on the severity of the valve. Didn't have much thromboembolic event. I'll get back to this. And the mortality was very low. There was one mortality here in the severe patient. Unfortunately, the information was not available as how did this patient die. But you can see here high morbidity and low mortality. So mortality in the patient with mitral stenosis really can be prevented, and it's really not acceptable if you treat the patient early. So I'm talking about early evaluation and intense follow-up really should prevent, one, the complication, and certainly the mortality. So the maternal outcome influenced by mitral stenosis, very low maternal mortality, very low maternal mortality, a high incidence of hospitalization. Most common cause of hospitalization is heart failure. Other common complication, SVT, rate of complication related to the severity of mitral stenosis. The fetal outcome, a very high rate of C-section delivery, not justified, by the way, not justified. Physicians feel that if they have a cardiac patient, they need to do a C-section, and this is wrong. in the majority of the patient, you cannot deliver the patient vaginally. There's no reason to do a C-section, but for whatever reason, you see here that patient with moderate mitral stenosis, 63% of them had a C-section. There's a high rate of premature delivery. It's a high rate of babies under the weight of 2,500 grams. There's a high rate of small for gestational weight, and the rate of complication related to severity of mitral stenosis. So severe mitral stenosis, if not corrected during pregnancy or before pregnancy, is going to have an impact on maternal outcome and fetal outcome, mostly maternal morbidity, rarely mortality, mostly premature delivery, and small babies in this population. The second case, a 34-year-old Hispanic female with rheumatic mitral valve, gravida 2, 16 weeks gestation, early. The history of also valvuloplasty in 2008, which at that time was complicated by stroke and mild to moderate mitral regurgitation. She is now also in class 3. The echo shows an ejection fraction at 50, marked left atrial enlargement. The mitral valve has 1.1. The mean gradient is 6. She has moderate mitral regurgitation. She has mild tricuspid regurgitation. The systolic PA pressure is only 33. The reason why she is symptomatic with what seems to be a moderate mitral stenosis and a mean gradient of 6 is the moderate mitral regurgitation. So when she walks, the pressures within the left atrium are really going up. Again, she has a heart rate of 92, which is an opportunity. You can see here that this combination of mitral regurgitation, which is shown here in green, and in this violet color, or whatever color you see here, there is a substantial number of patients that also have mitral regurgitation. Look at the moderate mitral stenosis. About 40% of the patients also have mitral regurgitation. So the question is, how does it affect the outcome? You see here, these are the mitral regurgitation patient in the EuroPac registry, the mild and the moderate to severe. About 20% of the patient with moderate to severe did have heart failure prior to pregnancy, and we said it is predictable that this patient will develop heart failure during pregnancy too. Almost 30% of the patient required medication, cardiac medication. Third of the patient had pulmonary hypertension. 20% of the patient had to be hospitalized before the pregnancy, and 23% had heart failure. So this is a high-risk population. It is not surprising that during the pregnancy, in spite of the fact that they had mitral regurgitation that is usually tolerated well, if they have all these parameters, a history, pulmonary hypertension, then they are going to have the same complication during pregnancy. So here you see the heart failure in 23% of the patient was moderate to severe. But if you compare it to the patient with mitral stenosis, then you see that the rate of complication is higher. So again, mitral regurgitation with LV dysfunction, pulmonary hypertension, a history of heart failure before pregnancy is not immune. These patients are also going to become symptomatic, but not as much as mitral stenosis. And the mortality was 0%. The mortality was 0%. So it means that these patients are manageable. So they are manageable. So if you have a patient that you basically see with moderate mitral regurgitation at the beginning of the pregnancy, it is not an absolute indication for termination. If you feel that the patient can be treated, you have a compliant patient, you have a system that you can follow the patient very well, you can do hemodynamic evaluation if you need, You can determine the timing of pregnancy according to the patient condition. So all of this is possible. To lower the risk, you have to see the patient or follow the patient very closely. We see this patient every 2 weeks until the 30 weeks of pregnancy, and then every 1 to 2 weeks until delivery. You have to remember that symptoms and physical findings in pregnancy may be deceiving. What does it mean? That means that normal pregnant women, and you see it here in gray, a sizable number of normal pregnant women without heart disease will present with symptoms of dyspnea. And you can see here the dyspnea level on climbing one flight of stairs, walking at even pace on level ground, or during routine performance of housework. So just go by the symptoms, it can be extremely misleading, and you should not base your decision about intervention or the timing of delivery just based on the symptoms of the patient. You need to have more. You have to follow the BMP. You use your echo to estimate the PA pressure, and if you're not sure, you take the patient to the cardiac catheterization lab and see what are the pressures within mostly in the atrium. So the wedge pressure, the left atrial pressure, is really the one that should determine the timing of delivery. I'm going to quickly go over the management here, and I know that I should leave some time for questions. So the management of mitral stenosis during pregnancy, we said that there is an increase in left atrial pressure because of the increase in the gradient across the mitral valve. So you want to make every effort to reduce left atrial pressure by either slowing the heart rate, right? Slowing the heart rate, or use a balloon valvuloplasty, or use diuretics. You don't want to use diuretics as your first modality because of the fact you're going to make the ventricle hypovolemic and the patient will become tachycardic, and that is going to beat the purpose. The tachycardia is the enemy. So you can see here the effect of the change in heart rate on the gradient across the mitral valve on the y-axis here. This is a patient with atrial fibrillation, and this is a patient in sinus rhythm, and lowering the heart rate is having a very significant effect on the gradient. So you don't need to use diuretics unless the patient is really volume overloaded, which is usually not the case in patients with mitral stenosis, but aggressive administration of a beta blocker will do the job oftentimes. You can see it here, a group of patients who deteriorate with mitral stenosis, and then you put them on beta blockers, and the majority of these patients will normalize. One thing that we have learned by an observation, and then we did a study, that in pregnancy, it takes a higher doses of beta blockers to achieve the control of heart rate. Here you see the heart rate in the third trimester and then postpartum in a group of patients receiving 100 milligrams of atenolol. You see the heart rate, but you also see the plasma concentration, which did not change. And in spite of that, after the delivery, there is a substantial decrease in heart rate, meaning that during the delivery, during pregnancy, you have an increase in sympathetic tone, and to achieve the reduction in heart rate, you have to give the patient more than the usual doses of beta blockers. The patient who do not respond should have valvuloplasty. 515 women, you can see here the results, the mean mitral valve area from 0.9 to 2, the mean mitral valve gradient 23 to 6, and the mean of the PA systolic pressure from 61 to 40. It is a relatively safe procedure in pregnancy. If you use a lot of echocardiography instead of fluoroscopy, you can minimize the fluoroscopy. The procedure was successful in 98% of the patient. 1.6% of the patient required surgery for mitral regurgitation, and the maternal mortality was 0.2%. So there can be complication, mostly mitral regurgitation, and the patient may need to go to surgery, and surgery is associated during pregnancy with fetal loss of about 30%. The second patient does not give you the option of valvuloplasty because of the degree of mitral regurgitation, and you need to treat the patient medically. This is the most recent report on the outcome of surgery during pregnancy, just published in the European Heart Journal this year. And you can see that the fetal mortality was high, especially in the first trimester, but also about 30% in the third trimester. In addition, there was also maternal mortality, which is higher than anticipated. So obviously, surgery during pregnancy is not desirable, and this patient should be aggressively treated with beta blockers and diuretics, and she actually did quite well. So the delivery quickly, when to deliver, we like to extend the pregnancy to 36 weeks if possible. And the reason for that, you can see that you had some complication in 17% of infants delivered at 34 weeks. This was reduced to 6% in infants and 4% in infants delivered in the 35 weeks or 36 weeks. And so because of that, we like to get to 36 weeks if all possible. So the mode of delivery very quickly, again, you know, I am against this phenomenon of a C-section, almost automatic, because of the fact that the patient has heart disease and the notion that the C-section is safer. It is not safer because of the increased risk of complication associated both early complication and late complication. So, so if all possible, the patient need to be delivered vaginally without risking the patient. But you can see, you know, this is the Indian group. You can see that they were able to do okay with a rate of C-section of 16%. Obviously, in the United States, even without heart disease, the rate of C-section is about 25%. But you don't really want to see 60% and 50% in a patient like this, because it is absolutely not necessary. And the rate of C-section delivery should be minimized. So in general, the vaginal delivery with appropriate anesthesia, which is usually epidural anesthesia, and shortening of the second stage is safe and can be performed in the majority of the patient with valvular heart disease. So I spoke for 45 minutes. I'm going to stop here, and I'll be happy to entertain some questions if you still have time. And if you ask the question, please ask them slowly and clearly so that I will be able to understand it in spite of the Zoom. Thank you.
Thanks a lot, Professor Elkayam. It was a wonderful lecture. So before I start with the discussion session, I want to tell you that we have the first cardio obstetric team in the country. Our local expertise is Dr. Edison Munoz and Dr. Jesus Velasquez. They are the men in charge of the team, and we're actively participating in research, education, and community work in the cardio obstetric team here at our hospital. Actually, we do have, maybe not so frequent like we had some years ago, but we still to have some frequency of rheumatic heart disease, and it's a frequent problem still for us. So we have a few questions for you. First being, what do you think about anticoagulation in mitral stenosis without atrial fibrillation? We know there are some recommendations regarding some echocardiographic features that could guide us to decide for anticoagulation despite the absence or atrial fib. What do you think about it, Professor?
Yeah, okay. So you can still see my slides?
Yeah, we're seeing it perfectly.
So the the recommendations, obviously, in a non-pregnant population is that you have a large left atrium, right? If you have a history of thromboembolic event, and if you have this, smoke in the left atrium, then there is a sort of a recommendation, obviously not 1A, to consider anticoagulation. Now, pregnancy is, as you know, as I said before, the incidence of thromboembolic events is higher because of the hypercoagulability. And so we had, we published this thing some time ago, but we had 3 patients that had embolic phenomena or thrombotic phenomena in patients with mitral stenosis in sinus rhythm. The first had an embolic stroke due to left atrial thrombus at 21 weeks. The mitral valve area was 0.9 and the left atrial diameter was 56. The second had a large left atrial thrombus that prevented valvuloplasty. The mitral valve area was 0.88 and the left atrial size or diameter 45. The third one had left atrial clot that partially occluded mitral valve orifice and led to pulmonary edema and urgent C-section with an anoxic brain injury to the newborn. The mitral valve area was 0.9 and the left atrial size was really not huge, it was 50. So I have been anticoagulating the patients with left atrial size over 55 during pregnancy, without a history of thromboembolic event, without necessarily the smoke in the left atrium. But this is my recommendation, and that's what we do. Now, the downside, obviously, is the bleeding. And we had a patient that had severe bleeding after the delivery. The patient went home and came back and on the weekend, and the young doctors who was there felt that the pain was the secondary to the patient developed hematoma and she had pain, that the pain was related to an infection, which is, common after the delivery. So the patient went home and the hematoma was allowed to grow to a size which was unacceptable. So, you have to pay attention to details. You don't want to use anticoagulation to prevent thromboembolic event in a condition which not everybody would agree they should anticoagulate the patient. And so definitely you want to prevent any bleeding complication.
Thanks. Second question is, how frequent do you use natriuretic peptides? Or do you use BNP or NT-proBNP? And do you have a regimen, or how do you use them?
Okay, so every patient who comes to see us for the first time is going to have a BNP level. Usually the patients who are relatively sick, will have also hemodynamic evaluation. I don't rely only on the echo, but you may want to rely on the echo, and what you really want to get is the PA pressure. So you want to establish the relationship between the PA pressure and the baseline BNP, because the BNP individually is not going to be to correlate with the pressure. So that means if you're going to look at the level of BMP, you're not going to be able to say, I know that the PA pressure here is 30, because individually it is different. But if you establish the BMP for one patient, for the given patient, following the BMP for the same patient is going to give you the information that you need. So it's important to understand what is this level of BMP means for this patient. You understand? If I know that the PA pressure, let's say, is 40, and the BMP, I don't know if you measure BMP or NT-proBNP, we measure NT-proBNP. If I see that the NT-proBNP for this pressure of 40 millimeter of mercury is, let's say, 200, and then I follow the patient and the BNP is going to 300, then I know that the pressure within the ventricle are increasing. Then we will follow the BNP depending on the severity of the disease and the presentation. So we will either do a BNP every time we see a patient, or that we will do it something like once a month. And certainly we will do the BNP again if the patient is complaining of increasing symptoms, or if we see, something that we don't like to see. The patient is telling us that they're not really able to sleep on one pillow. In pregnancy, it's very difficult really to understand what does it mean. In heart failure, if you have autopnea, it's fairly clear. Pregnant women, as you know, are not comfortable lying down on the back. And so they will use some pillows. So you have to ask them, is it getting better when you turn on the side? And usually it does, not in heart failure. You understand? But if you don't really know what exactly is happening, the patient is giving you a history, she's having decrease in exercise tolerance, which is part of pregnancy, then you do a BNP. It will help you to differentiate between the changes that you would see in normal pregnancy and hemodynamic deterioration.
Thanks, fully understood. Professor, do you have any experience of TAVR during pregnancy, or maybe aortic balloon valvuloplasty, or what are the strategies to use in aortic stenosis, severe aortic stenosis during pregnancy? Especially, my concern is about TAVR.
Okay, so yeah, so I didn't really have, so I would suggest that you basically go online and look at the paper that we published. This is, I'm now the associate editor of JACC Advances. Now, this is a new journal that part of what we are going to promote is cardio-obstetrics. So you're going to have excellent papers on cardio-obstetrics. We had a review, a very detailed review of what we call catheter-based intervention for valvular disease in pregnancy. And we had an extension, the discussion on the issue of TAVR. The conclusion is that TAVR in young women during pregnancy with aortic stenosis, mostly this patient have a bicuspid valve. It has a set of problems, starting with the radiation and the fact that if you have a bioprosthetic valve, the positioning and sizing of the valve is not easy. So you cannot use only echo. You have to use a fair amount of a CT scan, and that's associated with a CAT scan with a significant amount of radiation. Now, technically, it's not easy to really size the valve, and the valve may be too small, and you can see embolization of that. There is, a significant incidence of pacemaker as a result of the TAVR, depending on the valve that you're going to use. But even in the valve that causes less pacemaker, then recently it has been shown to be 6%. So if you put a pacemaker in a young woman at the age of 25, it has consequences. You know, it has consequences in terms of the effect on the tricuspid valve. It has consequences in terms of the need to change the battery. And there's information in the literature showing that it has effect on mortality too over the lifetime. So that's undesirable. Now, the valve, remember, is not calcified. So it's very difficult to anchor the TAVR valve, you know, appropriately without embolization. So it's not an ideal procedure for that. The valve obviously is going to deteriorate. And then what you're going to do, you're going to have another TAVR that you're going to subject the patient to a number of interventions during the lifetime. So no, I don't think that, and in addition, this patient eventually is going to have a valve. There is a significant impact of the TAVR on the wall of the aorta. And removing the TAVR is not always easy, and oftentimes is associated with damage to the wall of the aorta to the point that the surgeon has to do a replacement of the arch. So for all these reasons, we think that if all possible, if the patient needs help. So the first question is, does the patient need an intervention? And in the majority of the cases, the answer will be no. Don't be impressed with the symptoms of the patient. Get all the information that you need from the echo. Take the patient to the cath lab, look at the BNP, you know, see the patient exercise capacity, although it's not easy to see that at the end of the pregnancy, and make sure that the patient really needs to have the intervention. If the patient needs to have an intervention, we favor to do a balloon valvuloplasty. The valves, even in the rheumatic, are still pliable, not heavily calcified, and the results are usually good. Now, this is being used as a bridge to, right, the replacement of the valve after the delivery, if needed. And so, you know, that's really has been our approach.
Thanks a lot, Professor. One final quick question: commissurotomy versus mitral valve replacement. What kind of factors do you have to account when taking the decision?
Yeah, so you know, it's a very problematic area, and I am not fond of a bioprosthetic valve because of the fact that the valve don't last. Now, it has been sort of an estimate that these valves will last about 15 years. But in reality, we see the pregnant patient presenting. If you're looking at the same paper that I am referring to, you see that the valve-in-valve, the TAVI, which seems to be more actually successful when you do a TAVR within a bioprosthetic valve, but you see that the patient who required an intervention had the procedure or the valve replacement only 5 to 6 years prior. So the valve really at this age, and pregnancy probably also is accelerating the deterioration of the valve. So I'm not fond of a bioprosthetic valve. Now the mechanical prosthesis really requires a lot of attention. You have to have a patient that is compliant, is willing to come. You have to have a situation that you can measure anti-10A because we're using low molecular weight heparin. Or if you don't use low molecular weight heparin, even with warfarin, it has to be a regimen which is very, very strict. The patient has to come. Monitoring has to be performed. Otherwise, the patient is going to get into trouble. So, you know, it's between durability and a higher incidence of thromboembolic event. It's a discussion with the patient. If you have a patient that is not compliant, obviously they should not have a mechanical prosthesis. If you have a patient with atrial fibrillation, then it doesn't make too much sense to me to put a bioprosthetic valve, because you will need to have anticoagulation anyway. Maybe the intensity will have to be slightly high, but the patient is going to be followed for anticoagulation. So it's, it's a many considerations that go into this decision between you, the patient, and there's no perfect answer, and there's no perfect valve. But I don't think that automatically every patient in the childbearing age, every woman who needs a valve should have a bioprosthetic valve.
Okay, Professor. It was a wonderful session. Thanks a lot for your great lecture and for all your time and your answers. I think we could gladly finish our session. Thanks a lot. We feel really honored to have you here with us today.
Let me just say one more word, since you have now a cardiopsthetic team. We just finished the 7th Congress, International Congress of Cardiac Problems in Pregnancy, was in Porto, Portugal. In October next year, we're going to have the meeting in Abu Dhabi. In May, I'm going to have a cardiopsthetic session, which is going to be case-based. There's going to be basically a symposium that's going to be based on case presentation and discussion by the experts. It's going to be very educational. So pay attention to the announcement, and hopefully you will become part of this symposium.
Okay, perfect. We would love to participate in all those activities. I'm going to contact you later about
email me the name of the members of the cardiopsthetic team. I would like to keep in touch with them.
Perfect. You can count on that. So, Professor, have a wonderful day. Thanks a lot. We feel really happy to have you here today.
Thank you very much. Thank you very much for having me.
Thanks a lot, Dr.
Sure.
Uri.
Yeah.
Buen día a todos.
Yeah. Have a good day.
Have a good day.
Yeah.